thank you for coming, and let's get our presentation started. I'm Mike Tasto. I'm the treasurer for the NRHC, and I've been running around all day long. But glad to have you guys here. Bidyuth, you're first on the docket, so if you'd like to get started, the floor is yours.
Okay, I think you have to enable me to share my screen.
Got it.
Just quickly before we get started, Summera, let me know she's in the waiting room. So can you see if she's there?
Yep, just popped
Okay.
up. Participants can share simultaneously. Yes, and Logan McBride also is there. Okay. Bidyuth, did you get the ability to do that?
Yes.
Perfect.
Can you see my screen?
Yep.
Okay,
Yes.
cool. Okay. Can I say start, or are you gonna?
Yeah, go ahead. Yep.
Okay. Okay, so I'm going to start now. Okay. So hi everyone. My name is Bidyuth. I am a senior at the Macaulay Honors Program at Baruch College, and my research topic is to define what an investment is and separate it from other types of vehicles to put funds into the market. So the title of the presentation is what it means to have a vested interest, and the agenda for today is to address the intended audience, who retail investors are, define what it means to have a vested interest, introduce Benjamin Graham and Warren Buffett, have a definitive investment checklist, and finally Q&A if we have any time. So to get started, who are the retail investors? So retail investors are non-professional individuals who invest money themselves or through brokerage firms like Fidelity, Robinhood, mutual funds, ETFs. And as you can see from the statistics on the chart at the bottom, retail investors now account for the second largest volumetric movement in the entire stock market. That especially took a big rise pre-pandemic around 2019 and took a huge incremental rise during the pandemic and afterwards. And so these retail investors have big movements and plays into our economy and the stock market. And we wanted to know how they are impacting the stock market, what they are doing. Is it good for the economic community as a whole, or just a one-time thing? Have we seen this in the past? And what are its implications? So if we want to know what the impact that they have and how everyone nowadays is saying investing, so everyone that you and I know might know someone who is using Robinhood to invest money in the stock market. So we wanted to know what investment was and how we could separate it. So to start off, what it does it mean to have a vested interest? So an investment operation is one which, on thorough analysis, promises safety of principal and a satisfactory return. Operations not meeting these requirements are speculative. That was according to Benjamin Graham. We're going to go more into what it means later in the presentation. But first, let's see who Ben Graham is. So Benjamin Graham is known to be the father of value investing due to his contributions and works in the value investing field during the Great Depression and onward. He taught a very famous class called Security Analysis at Columbia Business School during the Great Depression. And out of that class came many prominent and legendary people that contributed greatly to the investment field thereafter. And he's mainly known for being the teacher and mentor of the legendary investor Warren Buffett, and also for writing the books The Intelligent Investor and Security Analysis. And so according to Ben Graham, he defines that he identifies three different methods that people perceive when they put money into the market, such as buying stocks. So you could be investing, you could be speculating, or you could be trading. So how do you differentiate the three? So according to Ben Graham, investing is supposed to be similar to conducting an inspection or an analysis. When you buy a new car or a house, you get it inspected to make sure everything everything in it is right and nothing is wrong. Similarly, you would analyze a company to make sure that the company's financials are correct, it's operating, it's creating value, it's growing, and it's not losing money. Speculating is when you buy a stock in anticipation of selling that stock for a higher price at a later date. And trading is more in the realm of speculation. However, you tend to have an idea of making small profits in small movements of stock prices on a day-to-day basis rather than on a long-term speculative basis. So how do you make an investment? You go through an investment checklist. An investment checklist, again, to Ben Graham, is an operation that you have to conduct. And you conduct the operation through analyzing the company's financials and aiming for a satisfactory rate of return with always building a margin of safety on hand. And anything that basically does not meet those criteria are speculative in nature. So how to build more into this checklist, what a retail investor could be doing is looking into the 10K accounting consistency of a company. So which means that this particular company, whichever company it might be that you buy a stock of, they must have the same reporting style on a minimum of 3 years trailing. So some companies change their reporting accounting style, and that just means that they're trying to hide something. And having consistency in the financial world keeps everything at a more prospective nature. You must read the proxy statements. The proxy statements usually tell you what the insights of the company are, where the management is looking forward to, and how the company is actually performing relative to its competitors and the market as an overall. So, and you could also be looking at a more deep dive into quarterly reports, tells you any updates or events that may impact the companies themselves. The management style, which can also be found through the proxy statements into how they are. The management must be willing to usually be work for free without stock option compensation. If you see a management in a company where stock option compensation is the main driver for the management to be working, it usually means that the management could be bought out and that the entire company might not be institutionalized, but rather one person centric company, which is not good for an investor. And then finally, you must understand the economic dynamics of a company before you buy the stock. So this is where your circle of competence comes in. Some people know about beauty products, some people know about financial companies, some people know about car companies, others know about manufacturing firms. So whatever your circle of competence is, what you're most familiar with, you must understand how that company makes money. So for example, Apple, they make most of their money selling the iPhone. However, recently they've been changing their business model from becoming the major iPhone seller where they make most of their money to providing services such as Apple TV, Apple Music, and trying to get a reoccurring revenue model instead of just one-time fix that comes in constantly. Apple Care is also an example of how Apple is slowly moving from selling a manufacturing unit of an iPhone to selling services. So that's how economic dynamics could change in a company or illustrate where the dynamics are flowing through. And so I was asking all of this, what an investment is, how it's defined, and wanted to learn what the retail investor is, how they're impacting it. And the biggest example that all of us could relate to is the GameStop question. When earlier last year, we all over the news, whether financial news or regular news, everybody knew about GameStop, or like how it's impacting everywhere, how the small guy is sticking up against the big guy and taking over Wall Street, how there's maybe a financial revolution, etc. And so I wanted to know, like, what is driving this and how is it going to impact everyone in the long term from a general consensus? So the question addressed, if you look at this particularly, this is the stock price of GME historical trailings. And you can see that by January 28th of 2021, price jumped all the way up. And so what does that mean? How does it impact everything? Well, that is why I started this research. And what I came to was that the best return on investment over the 10 plus years comes from running an investment operation. And anyone who doesn't adhere to filling up the checklist that was mentioned earlier by reviewing 10Ks, quarterly statements, proxy statements, they are most likely going to lose their money. And that is not something good that we want to see. And so investing is not easy, and not everyone can by nature will perform above average. However, using the investment checklist, many general public people could hedge themselves from speculation and trading by making sure they fill up every single thing on that checklist and making a sound decision based on their own judgment. And so that was my presentation. Thank you.
All right, we still have a couple minutes for questions if you ask questions, and then we can move on.
Yeah, I have a question. So that's my son actually made money on GameStop. So this is interesting to me. They just did it as a lark, and they put in a few $100s, I think, and they doubled their money. So they had fun. But my question is actually, it sounds like from your checklist that if you do all those things, look at the statements, the quarterly reports, analyze the management style, make sure you understand the economic dynamics of it all, then you'll probably be making a good investment. But I feel like that's not true, because we all know that there are things that happen in the world, elections, wars, hurricanes, like other factors that are going to have an impact on all the things that you studied. If everybody knew how to do this, which you would think that the investment companies know how to do this, and yet still people aren't making, not everybody is making a ton of money, and things happen and markets crash. And so do you have any thoughts on that?
Yeah, so the macroeconomic play within the investment analysis field, that's more of so there's two types there's intelligent investing and there's intelligent speculation. That goes into the field of intelligent speculation, because yes, there are a lot of things happening in the world, but the impact of those things into a particular company's operations is not necessarily felt directly and cannot be linked in any way possible. And if they are, they become usually reflective within those proxy statements or 10Ks or quarterlies, and anything else could be just everyone just saying, oh, there's a war coming, so oil's being affected, etc. But in reality, the operation of a company is different from the macro events that usually happen.
Okay, thank you.
Yeah, I have a question for you, Bid. So you have this checklist, which is great, but if there's somebody who is interested in making an investment who doesn't have kind of the requisite time to go through all of those steps, what would you advise them to do if they'd like to make an investment?
So the most sound investment, which has been actually on the rise in the past decade, has been just passively investing in an S&P 500 index fund. But that would just mean you would be trailing the market average and not necessarily getting anywhere ahead. So this is meant for retail investors who don't necessarily invest in index funds, but are actively putting their money in individual stocks and shares of companies. So for anyone who does not necessarily have the time to look through the checklist and fill it all up before making a sound purchase, then their best bet of option might be either finding someone they trust, like Warren Buffett, investing in them, or an S&P 500 index, a market average index.
All right, thank you, Bidyuth. Our next presenter is Christopher Melendez. Christopher, if you want to introduce yourself and got about 15 minutes for your presentation. I'll send you a little 5-minute heads up warning too.
Okay, thank you. Let's just share this. Sorry. Okay, you all can see my screen?
Yes.
Okay, perfect. So my name is Chris. I'm a student at the Macaulay Honors College at Hunter College. I'm a biochemistry major. And also for context about me, I work in an optical alongside an optometrist. I work as an assistant there, and I also work as a medical biller. And after this, I'm looking to go into optometry school. And my experience in the field is mainly what led me towards my research topic, which I titled Seeing Things Differently After COVID-19, Advances and Setbacks in Optometric Telemedicine. So today I'm going to break down my discussion into 4 different groups. The first thing I'm going to do with you guys is just introduce you to what optometry is, in case you're not familiar with that. Then I'm going to be talking about this idea of medical deserts, specifically in America. Then I'm going to be introducing to you different forms of telemedicine in the field of optometry. And lastly, I'm going to talk about the different solutions and challenges that telemedicine offers and faces in optometry. So what is an optometrist? I think a lot of people, when they think of an optometrist, either have no idea what I'm talking about, or they think about the person that they see at an optical who does that traditional 1 or 2 eye exam, and you walk out with either glasses or contacts. That 1 or 2 eye exam is just one of the things that a doctor does with you, and that's called a refraction. But what optometrists are really is primary eye care providers. So they are responsible for diagnosing and treating ocular disease. They're looking for things like cancer in the back of your eye. They're looking for damage to your optic nerve or glaucoma. And what my research really focused on was they're looking at patients with diabetes, and they're looking for any diabetic eye damage. People who have diabetes are susceptible to a disease called diabetic retinopathy, which causes these leaky blood vessels to form in the back of a person's eye. And when this is left untreated and uncaught, it can lead to permanent vision loss. But if a patient catches it early, they can be put on injections to help stabilize their eye, or they can be referred for immediate surgery to help protect their eye. Either way, when it's caught early, it generally means a patient can save their vision. When it's left unchecked, it can most of the time lead to permanent vision loss. Now, this is a problem in certain groups of people where they're unable to access healthcare. And this brings me into the idea of medical deserts. I think a lot of people, when they think of a medical desert, it's kind of been a buzzword in recent years. They think of rural medical deserts. And this one is a little bit more straightforward. It's this idea that doctors are really far away from their patients. There's a shortage of doctors in these areas. Sometimes patients are driving over an hour to see their doctors. And these doctors have sometimes 3-month-long waiting lists just to see them. And then when you get in, you might be waiting for an hour or 2 to still see the doctor. This makes the whole experience of seeing a doctor quite inconvenient. This means patients have to take off a day from work. They have to pay the gas to go ahead and drive over to their doctor, which right now is like $60 a tank. So it incurs all of these extra costs, and it makes it that much harder for people who need an eye exam every 6 months to a year to get them. In urban areas, it looks a little bit more different because everyone kind of thinks there's all these doctors around. But for a whole bunch of reasons, urban medical deserts are characterized by patients presenting to hospitals with permanent vision loss, with very debilitating conditions, rather than getting more preventative care. I'm not going to get into all of that right now just for the sake of time, but I'm going to talk about how telemedicine has been looked at as a solution for this idea of both rural and urban medical deserts in regards to optometric care. I'm going to break up my discussion of telemedicine into 2 forms, asynchronous and synchronous. Asynchronous telemedicine is really referring to technology that's delivering eye care to patients without actually directly interacting with a doctor. One example is 1-800-CONTACTS offers a service called Express Exam, which allows patients to renew their eye prescription at home. The way this kind of works is a patient will set up their computer, they'll stand about 10 feet away, follow some prompts on their phone, and that'll allow a patient to do that at-home refraction, that 1 or 2 eye exam, to see if their prescription is working good right now, or if not, Express Exam is able to kind of tweak prescriptions just a little bit to try and get it on track. That prescription is then sent over to an ophthalmologist for them to sign off on. Now, there's a few problems with that, and I'll try and get into that a little bit later on, but that's one example of asynchronous telemedicine. Another kind, which my research really focused on, was remote diagnostic exams, and specifically I focused on fundus cameras as an example of this. Now, treating and diagnosing disease requires getting a look inside of a patient's eye. One machine that's able to do that is called a fundus camera. It takes a picture inside of a patient's eye at the back of their eye. This photo is then sent over to either an optometrist or an ophthalmologist, so they can go ahead and review that picture at their own time. The advantage of this machine over seeing a doctor is that these machines can be put in a CVS, in a Target, in a Walmart, or they're also employed in doctors' offices too currently. But the advantage of putting it in a CVS or a Target or a Walmart and being operated by a technician rather than a doctor is that we can cut down travel times in rural areas, where instead of traveling an hour, you can go ahead and get your groceries at Walmart and get your eyes checked at the same time. It'll help expand care, especially to those patients that really need constant exams. Other forms of telemedicine are synchronous forms of telemedicine. Synchronous meaning that a doctor is constantly with you throughout the exam, normally in the form of a video call. One idea of synchronous forms of telemedicine is virtual at-home visits. This is common in all forms of healthcare. It's pretty much a Zoom call with your doctor through a HIPAA-compliant portal, not Zoom, but the doctor will go ahead, video conference with you, and they'll go over normally follow-up care results. They'll go over any results you did in person, or they'll go ahead and renew prescriptions for you in case you're on any drops, like for glaucoma or for dry eye. And really it's there to help save patients that trip to go see that doctor for a 5 or 10 minute quick checkup. It can also be used to diagnose things like pink eye or help check on any external conditions in the eye. There's this other case that's a little bit more unique to optometry, and that's this idea of remote clinics. So first, talking about what a remote clinic is, it's a patient receiving all of the elements of a normal exam without the doctor physically being there. The way this works is the technician normally does all of the in-person elements. They move that phoropter in front of a patient's head to do that traditional 1 or 2 eye exam. That technician will also take pictures inside of your eye and also on the outside of your eye. They'll check your eye pressure, and all of that gets sent over to the doctor immediately for immediate review. And the doctor will control that phoropter remotely to do that 1 or 2 eye exam with you. In a remote clinic exam, you're getting immediate feedback and immediate review from a doctor, and you're still receiving that same level of care, just with the doctor working remotely. This has a few benefits. For one, it's a lot cheaper as far as administratively, because one doctor can operate 3 or 4 remote clinics at one time. So this can help lead to expanded access of care because it's a lot cheaper administratively to do it. Additionally, it can expand care into certain rural communities where generally doctors don't work in these areas because it's seen sometimes as undesirable to work there. So a doctor who's working in New York could establish a remote clinic and still deliver care to needed areas. It can also be employed in urban medical deserts in places like Bronx or Jamaica, Queens, to go ahead and deliver care where there sometimes isn't always an abundance of doctors working in these areas. So what are the solutions that telemedicine offers? The first and most obvious one is patient convenience, whether that be saving patients a trip into the office with those virtual at-home visits, or saving patients an hour-long commute to go see their doctor when they can get that same inside of the eye look at a Walmart with one of those machines, those fundus cameras. Again, expanded access to care, opening up these clinics in rural areas or urban medical deserts. They're cost effective, and I put a star on that because I'm going to get into that a little bit more, but they're cost effective in an administrative point of view. A lot of times operating one of those fundus cameras is cheaper than paying a doctor to go ahead and look inside of your eye. It's a lot cheaper for a practice to employ a remote clinic service rather than staffing a full-time doctor, or a doctor running 4 or 5 remote clinics to see that many more patients. They're cost effective in this administrative point of view. They're also easy to deploy. A lot of these just really involve putting a machine out there and getting a technician to work for you. Or some of these fundus cameras now that are coming out are fully automatic without even needing a technician to work them. So these are the advantages of telemedicine. In the pandemic, a lot of these are really important. The big thing that a lot of people worrying about were risk of exposure. A lot of people didn't want to go out. Because they didn't want to go out, we needed ways to see people a lot more conveniently and a lot more without having to make that trip out of the house. It also allowed doctors to see more patients when they were told that they couldn't see a lot of patients in their office. So it was good in that way. Some of the challenges that telemedicine has faced is that it's received pushback, especially from optometric unions, especially in the case of 1-800-CONTACTS Express Exam. They listed their main concerns as safety, but others argue that that concern is more of being replaced by technology. There's a lot to unpack there, and I don't have the time for that. Another challenge that telemedicine faces is that it's not always covered by insurance. And there are different reasons why insurance will choose to not pay for a telemedicine service. At this point, most of them are kind of approved in an FDA way. So there's no reason for them to not be paid out by insurance, but there's a whole bunch of different reasons that are causing them to not always be paid. And when that happens, that means that now something that could be free if they make the trip in now needs to be paid out of pocket by patients. So those are some of the challenges that it faces. That's pretty much it for me. So if you guys have any questions, feel free to ask me.
I have a question. I really enjoyed your presentation. So I teach a class on medical ethics. And to me, it seems that one of the ethical issues that might arise with this is the question of patient privacy in terms of people being able to hack the computer and find information about patients. In fact, we had a Springboard student once who did her Springboard about how easy it is to hack healthcare stuff. And in terms, you could like end up getting the wrong amount of insulin. Those are the kind of examples that she was giving. And so I'm wondering if that came up in your investigation.
So it wasn't so much a focus of my research. As far as these technologies stand in America, all of these technologies have to stay HIPAA compliant in all of the ways that they work. So they're held to the same standard that, an EHR system or the way that they keep health records in a hospital, in any doctor's office, they're all held to that same standard. So it's as safe as everything else healthcare is in America. But
that makes sense.
That's as far as I really have an answer to provide for that.
Yeah, I wish I still had what she presented, because it would like blow your mind to see. She showed kind of the back. Remember this, Lisa, when she showed like the back end of a computer and what goes on, and at all the different junctures where people's information could be easily exploited. And in as you say, though, not just in this, in the hospital and the doctor, in the record keeping and Epic, all the ways that they keep records. It was really frightening, but there's nothing we can do about it. So we move on.
Lizzie, my wife, actually works for the second biggest one, eClinical Works. And so she deals with these health record problems all the time. And some of it is scary when medications are pushed through the system incorrectly.
Yeah.
Or missed. Yeah. So thank you, Christopher. Nice job on your presentation. Let's get on to number 3, which is Sandi Bajrami. Sandi, you got the floor for about 15 minutes, and I'll send you a 5-minute text message on the chat. Okay. Good luck.
All right. Hi, everyone. My name is Sandi. I'm a student at Macaulay Honors College at CUNY. And today I'd like to share with you some insights about precision medicine and what the near future of medicine may look like. So first, a proper definition for precision medicine. It's a new framework that leverages various techniques and technologies to specialize medical treatment to small patient subgroups. So this model addresses the vast genetic and biological diversity between patients that the one drug fits all model overlooks. So this is especially true in cancer. So the main difference between standard medicine and precision medicine is sort of designing it so that it can better fit the person rather than focusing on the disease itself. So in order to build out a framework that's more specific to the patient, you would have to develop like 4 different subcategories. So first would be diagnostics. So in order to succeed in this framework, you would have to collect as much information from the body as you can so that you can know very precisely what's going on and what treatment would be most effective. And since you have all this additional information, you can design more powerful and more specific treatments that are more unique biochemically and that could more selectively target the disease in the patient's body. So in order to test these treatments, you could use some new models, new tools that better represent the patient's body. And this can be done in the clinic or in academia to test new drugs and new treatments. And fourth, putting it all together, this framework would generate a lot of data. So we can use artificial intelligence to make it all actionable. So first is diagnostics. So first, one example of this is whole exome sequencing. So DNA can be divided into the exome. So exons and introns. So exons make up the exome, and this section of the DNA this is the section of the DNA that that codes for like proteins that actually have like known activity in the body, and introns are less understood. So in a study conducted by scientists, they found, well, first, some more information on whole exome sequencing. If you take all the information from the exome, you can find different mutations in genes, and you can find drivers of cancer. And this was made possible by next generation sequencing, which was developed in around 2005, but has become more accessible now because of decreased pricing. So whole exome sequencing was performed on a patient that suffered from recurrence of cancer after surgery. And this was an extremely rare case because the patient actually had 3 separate occurrences of cancer that were independent of each other. So this occurred in the esophagus, lung, and the liver. And current medical techniques would not be able to catch this. They would just assume that it derived from the same cancer and there would be a metastasis. So with this additional information, we have different targets and these cancers would also have different morphologies, so they would respond differently to different treatments. So this information can help us develop more comprehensive treatment plans. So with this information, we can design more powerful and more selective therapeutics that can target cancers better. So the reason that they would be more effective is that resistance is a very common limitation to cancer treatment. So over time, as a cancer is treated, it can become resistant to drugs that were previously effective. So this means that treatments can only work for a specific period of time, but then the cancer can adapt and change its properties so that it can shield itself from certain drugs or therapies. So in response to this, scientists have developed very specific and very powerful treatments. So one example of this would be an antibody drug conjugate. So an ADC, picture to the right, has two parts. It has a monoclonal antibody and some sort of toxin. So the antibody can bind very specifically to some known antigen, which can be anything that is unique to a certain type of cell. And then it can localize the toxin to that exact cell. So this would limit damage to other areas of the body. It would very effectively reach the certain tumor that you're trying to reach. But the limitation to this is that it's hyper-specific, and it would be difficult to use broadly, and it would be difficult to know exactly when to use it. So another example of these modern treatments are immune checkpoint blockers. So oftentimes, cancers can use the immune system to their advantage by creating immunosuppressive environments so that the body has a more difficult time attacking it on its own. So in response to this, we can create drugs that can modulate the strength of the immune system so that it can regain its power to target these tumors on its own. So as a response to all these new treatments, it would make sense to develop models to test them on outside of the body. So one example of this is organoids. And organoids are usually derived from stem cells or directly from tissue from a patient's body. So organoids can be thought of as the next level of cell culturing. So cell culturing is very commonly used, but it's usually two-dimensional and does not have the same complexity of many organs or tissues. So organoids can self-assemble and create complicated 3D structures that are very similar to what is seen in the body. So using these tools, we can test hundreds or even thousands of different compounds against like one type of tissue. So they can be used directly in the clinic to test if a certain treatment would work for a specific patient, or they can be used academically to test different treatments for a very specific type of disease. So, yeah, so in order to successfully use organoids, scientists have developed biobanks, which are basically databases that contain large information on different types of organoids. Because for even one very specific type of disease, you can make hundreds of different organoids that mimic very small alterations in the cell that are found in that disease. So as a result of all this new information and new data. We need more powerful tools so that we can make these insights actionable in the clinic. So artificial intelligence would be the most relevant tool to analyze and make use of all this data. So in one example of artificial intelligence, we can use it to analyze all relevant biomarkers. So anything that would be related to disease progression. Another thing we can do is design more effective drug combination therapies so we can maximize the intended effect. So one example of artificial intelligence that is currently being used is to optimize combination therapies for cancer treatment. So Curate AI basically measured biospecific or prostate-specific antigen for prostate cancer to monitor disease progression in response to two different chemotherapy drugs. So the scientists were able to optimize the drug dosing as a result of monitoring disease progression. And this is important because every patient will probably have different doses that they will most effectively respond to. Okay. So that is all. If you have any questions.
All right, I have a question. This is really interesting. I don't know anything about this, so you can just tell me if this question is idiotic, which it could be. But I've heard that a critique of precision medicine is that because it relies so much on really expensive things like next generation sequencing and things like that, AI stuff, is that a simpler approaches would be better because they're going to end up benefiting more people. And so hearing like your presentation coming right on the heels of the one before us where people can't even afford to go get an eye exam, I'm just wondering, like, sorry, hold on a second. Wondering, you know, are people going to be able to access this kind of medicine? And have you read in your research of any groups that are, or companies that are kind of coming up with ways to make this kind of healthcare more equitable and just?
Yeah, that's definitely a great point. So at the moment currently, it would not make sense to make everything precision medicine based. But like over time, technology does get cheaper. And I think we can reasonably anticipate that it'll be more accessible. Like for example, one of the technologies, whole exome sequencing.
Oh, Sandi, if you could just repeat yourself, unless it was only me, but right when you started to begin speaking, I think you broke up.
Oh, okay. Well,
Is
so
it
yeah,
just me, Lizzie, or could you guys hear?
Yeah, I heard what he said. I think it might have been just you.
All right, forget it then. The Shah the answer. All right, thank you.
so yeah, for example, whole exome sequencing, it was extremely expensive when it first came out, but it has become extremely popular to use, mostly academically and more popular in clinic too, very recently because of substantial decreases in pricing.
Okay. I mean, I guess it makes sense because everything when it first starts out is super expensive and then over time it gets cheaper.
Yeah. The problem is it's a little bit unpredictable, but like it's unpredictable by how much the price will decrease.
Mhm.
But generally over time we can expect I think major price decreases. It just may take a lot of time.
Right. Thank you.
Yeah.
Lisa.
I've also got a question for you. So let's say that you are a person who, I know that, you know, most of the people who are here on the Zoom live in New York City, and there's a lot of major medical centers here, and you could probably ask for a referral to get some kind of treatment with precision medicine because we have access to like Sloan Kettering and all sorts of places like that. Let's say that you lived in one of those medical deserts that Chris was talking about, but you were given a diagnosis that could be helped with precision medicine. How would you go about being able to find somebody who could help you with precision medicine?
That's also a great point. Living in those medical deserts would definitely limit access to precision medicine. But another like great thing is that since it's so based on technology, maybe you can cut out the need for very specific like meetings in person. So like, for example, maybe you could send a DNA sample to a lab and then receive those insights online, and then the physician can know exactly what to do, even if they aren't necessarily trained in that specific field. Because the artificial intelligence insights can also guide their treatment plans.
Thanks. It almost sounds like there's like remote clinics that Chris was talking about, that there could be somebody who did precision medicine, but kind of like had a network that they were working with where they were getting the information virtually and then pushing information back out to those clinics to help them treat their patients.
Right, yeah, exactly.
All right, well, thank you, Sandi. Our next presentation is Summera Shah.
Hi.
Thanks. Good luck.
Can everybody see this? So hi everyone, my name is Summera Shah and I'm a student at Macaulay Honors College, CUNY. So the topic for my presentation is telemedicine, the bridge between rural and urban healthcare. So access to poor healthcare services is a critical aspect of healthcare in general. It is important for promoting and maintaining health, and access to quality healthcare services also enhances the disease prevention and management and averts preventable disability and premature demise. So while developing countries have the privilege of accessing quality health and advanced medical services, people in low-income regions lack such services. So there are many factors that have led to such results, including healthcare infrastructure, geographical location, transportation, health information, medical personnel, and the general availability of service. As a result, people living in areas with poor healthcare access service experience poor health outcomes, leading to poor general quality of life, and in general, just like a bad result. So my paper explores the barrier to access to proper healthcare for people in remote areas of the Swat region of Pakistan, and it also highlights the steps of telemedicine that could be implemented to solve these problems. So some of the challenges that people experience due to living in such areas where the healthcare is not properly accessed is, so as I said, one of the areas is northern Pakistan, which is Swat. It's a district in northern Pakistan. So Pakistan is one of the countries that is lagging behind in health-related indicators compared to other nations in the region. And one of the major causes of this infrastructure is the dysfunctional healthcare delivery system. So the remote areas of Swat lack healthcare infrastructure such as hospital, modern data and information systems, as well as capable and coordinated workforces. In other words, fail to build healthcare facilities in remote areas, making it challenging for people to access services. Also, the poor coordination and communication between healthcare agencies in the countries limit the government's capacity to identify the problem with healthcare infrastructure and address them properly. So one of the main barrier that arises in these areas is transportation. Transportation is the major limiting factor when it comes to access and these areas. Reason are not all spots, but majority of the separated from the country's region by distance and transportation. Some of these areas have to travel before they can access care services, which could be fatal for some cases. So when it's not like 10, 20, most of the have to travel hours to get to a proper to be seen by a doctor. Now, not only does this increase the cost, but also consume a lot of the time of these patients. People in cities are able to use you can easily use the transportation to get medical attention. The situation is different in these areas because of these roads. A lot of cars aren't able to get to rural areas, and people have to pay just to get or to rent a car just to go to the hospital. And then people with chronic conditions who need regular attention, so for us to travel back and forth for short periods of time. The local workforce. So health workforce is integral in providing equal and equal care in a country with limited resources, such as Pakistan, such as the place in urban areas. So it's very late out of these things and not to look at short areas. So rural communities experience a shortage of health. And some spots or areas residents have used medical conditions that can in that specialized as well as that, the spots. Not really.
Summera, I'm so sorry to interrupt, but your audio is cutting out a little bit. Do you think is there any adjustment that you can make on your side?
I connect to my Wi-Fi so I can use it. Well,
Sorry, I couldn't hear that.
I know, we can't hear what you're saying. All of a sudden it started.
It was fine at the beginning. Try if you can go to the button by your microphone and do like a test of your microphone maybe, or see if it gives you options there for which microphone to use.
She might be able to turn off her video as well to increase
That
her
could
depth.
also help.
But I wasn't going to say anything because last time it was only me. So
hello?
That
Can you
sounds
hear me
more
now?
clear. Yes.
Yeah, that's better.
So what was the last part you guys heard? I can just continue from that.
I think just start from this slide, maybe.
Okay. So one of the thing is the a well-qualified health force, which is an integral part in providing equal and accessible care. In a country with limited resources such as Pakistan, the majority of health caregivers operate in urban areas, which are very dense and populated areas. And people tend to not look at these rural communities. And this causes a great shortage of healthcare workforce. So some of the SWAT rural area residents have unique medical conditions that have to be seen by specialized doctors. And but because of the lack of workforce, people aren't able to see the doctors in the right time. And in addition to this, the socioeconomic situation in SWAT rural area cannot attract private healthcare providers to invest in these regions, which this means that these people, when you go to these places, there isn't a lot of, it's not highly populated. So workforce workers tend to believe that if I go there, I'm not going to make a great income. Therefore, they tend to stay near the cities where there are more people. And then besides the limited resources inhabit the government, limited resources inhibit the government from deploying sufficient caregivers, and then which leads to a poor advocate service from that. So which leads to poor advocate service. Another thing is poor healthcare literacy. So this also negatively negatively affects the healthcare services in the remote areas of SWAT. So healthcare literacy affects an individual's understanding of health instructions and information provided by the practitioner. So poor healthcare literacy is a matter of concern in rural communities, as most of these people living here are not highly educated. Just recently, I believe like people have started to take education very seriously in Pakistan, especially like last decade. But before that, many people, especially the poor communities, did not really go to schools. They would rather go to a job to earn some money and help the house. So majority of the elders living in these communities cannot read or write, which means that they won't be able to understand the information provided to them by the doctors. So a solution to this is telemedicine. So telemedicine refers to healing from a distance, and it uses technology to increase access to medical information and healthcare services for better patient outcomes. So when implemented in some rural communities, the practice has proven to be a vital lifeline. It has efficiently addressed workforce shortages, therefore addressing the individual who would have to travel long distances for treatment. It also allows patients to consult with specialists remotely, and these healthcare facilities in rural areas can also outsource care service to advanced healthcare facilities to enhance health outcomes. So Pakistan can use telemedicine to promote access to care in SWAT's rural part and connect them to the city's doctors. So this can be done in two ways. One is live video. So this means that you would be sitting face to face using a database that allows you to connect to the doctors in the cities and to you, and then you can just sit face to face, talk with them, and then consult with the doctors. Another way is store and forward recordings. So what this means is that a technician or a practitioner would be in the clinics where these telemedicine would be provided to take your vital information and then take your height, weight, any symptoms that you're experiencing, and record them and then upload them to like any type of database that is provided, that is also available to doctors, and then they can access that information and then therefore provide a diagnosis. So implementing telemedicine can be a bit difficult in such situation, but it's also very beneficial. So Pakistan can apply telemedicine to work with simpler admitted to specialists and trained professionals. Quite possibly the clearest way telemedicine can connect the healthcare practitioner in country regions by expanding patients' admittance to providers. So telemedicine also empowers patients to get a specific sort of care when they need it, as opposed to heading out to an office or holding on to get an arrangement. Pakistan can use telemedicine to eliminate the challenge of poor transport infrastructure, and so Pakistan in country settings or rural settings probably will not have the necessary resources to make a trip to a provider, which can be very tiring and drawn out. And more seasoned or less portable patients would also likewise have like a family member that would have to go with them, as I said, that these people are not literate. So in a way, it kind of takes that back too, as somebody would be provided to them in their specific location to speak with them in the language that they can best understand. Pakistan can also address the challenge of poor coordination and communication by implementing telemedicine. So telemedicine enhances the collaboration effort and efficiency of clinical staff, which works on the nature of patient care. So a review that overviewed emergency units observed that 79% occurred tele-ICU frameworks empowered the attendants to work on patients, while around 75% said that it further developed work execution. So, and then telemedicine additionally decreases emergency clinical costs by giving remote admittance to experts in these rural areas. So telemedicine has expanded popular in the light of the fact that it permits patients to stay in their home or local area as they get care. Heading out to these medical clinics can be more awkward or even difficult for patients, but being in a steady, real-life climate might encourage a speedier diagnosis. So possible drawbacks to this is the hindrance in telemedicine is admittance to dependable broadband or satellite, since live video does require fast internet. And then also programmers and different lawbreakers might have the option to get these clinical information by hacking into the system. Now, I do understand that this is a huge risk, but I feel like when we look at these settings, it is a risk that the people should be willing to take, because even like now, currently, I feel like everything is going online. So even if you are situated within a hospital, you don't really have 100% guarantees that people won't hack into that hospital setting and get the information they wanted. So some possible recommendation to the solution would be a governmental investment in telemedicine. So to the places that don't have these proper connection to internet, the Pakistan administration should ensure that these regions have broadband and satellite to facilitate transmission. So they can set up towers that ensure fast interfaces. And then also medical practitioner. And when it comes to the hacking and getting this information, medical practitioners should be trained on how to use the technology properly and to use the equipment properly to ensure the privacy of these patients, as well as providing care to them. So in conclusion, the rural areas of Pakistan, or the Swat region of Pakistan, is very isolated, and the people in the region face numerous barriers to access proper healthcare service. The lack of access is attributed to a broad array of factors, which include health infrastructure, geographical location, transportation, health information, medical personnel, and the general availability of services. So people living in these areas with poor access to healthcare service experience poor health outcomes, which increase disability and mortality rates, and poor general quality of life. The implementation of telemedicine will save care costs, minimize the need for transport, enhance convenience in the process, improve patient outcomes, and promote the general advancement of the Pakistan healthcare system. Thank you. And you can contact me for more information at my email.
I have a question, Summera. First, I just want to say Ramadan.
Sorry, I didn't hear that.
Okay, can you hear me now? Can you hear me? No? Lisa can.
Oh, I don't hear anything.
I'm not on mute. Okay, I'll
maybe it has, yeah, put it in the chat, I think.
I'll put it in the chat.
Yeah, it's on my side. I don't hear anybody. Just give me a second.
You don't hear anybody. Okay, so I'll write it in the chat. Now we can't hear you. Could you hear her, Lisa?
Hello, can you hear me?
Yeah.
Okay, I hear you too.
Okay, good. Yeah, I was just thank you. I mean, that makes sense. And I just was writing back that it'll take a while for people to get used to the idea because,
Yeah.
I mean, we're not used to, I feel like the doctor-patient relationship is like one of the most intimate relationships that there really can be. I mean, the doctor's looking at your body. We're kind of used to that. And then telemedicine is like the extreme opposite of an intimate relationship. It's like,
Yeah.
what could be more, disconcerting in a way, and yet the convenience of it and everything. I mean, I feel like I really hope it does take off for a lot of things, not only in Pakistan, but here too.
Yeah. So the healthcare system is very like up in the air in Pakistan right now, because up until now there was no such thing as health insurance. So whether you're dirt poor or like extremely rich, you would have to go to these doctors, and most of them are private doctors. So they would give any price they wanted to these people, and people would have to pay. But so now they have like introduced insurance, and then hopefully like telemedicine would be covered with insurance for these people. And I did have a question from one of my classmates saying that, how does this affect the cost? But I feel like it does improve the cost a lot, because if you are going to these doctors, these city doctors, you don't want to see any regular doctor, but you would want to go to specialists, which are generally more expensive compared to like regular doctors. So it's kind of like you're seeing a regular doctor, which can connect you to the right people. So that would also like decrease the cost efficiency.
Yeah, thank you.
Just last week and a half ago, we had the flu in our house, and it was terrible. My son had it, and then he gave it to me, and I felt so bad. So I went to the doctor. It's a Minute Clinic, and got diagnosed with the flu, and they gave me a prescription antiviral, and made a world of difference. One day, I was completely back and was feeling great. Consequently, my daughter started developing symptoms, and so I was like, okay, I already know what she's got. It's been going through our house. Let's nip this in the bud. So we did a televisit with her pediatrician, and diagnosed the prescription antiviral for her over the phone, and we picked it up the same night. Now, the cost differential is there, right? But now think about this: we saved a visit of my daughter who is sick and had symptoms, and me taking her there to go into the pediatrician's office, touching handles and doing all of that. So there's savings there on the potential of not infecting other people. So
yeah.
Well,
I mean, it makes sense all the way around.
but you do lose a lot of that personal. For some things, Lizzie, I think I would go that route, but other things, I don't think so.
Yeah. No, I agree. It's nice to have the option. And then obviously you can't go to the dentist, telemedicine. You need them to look at your actual teeth and do something. But certain things like just saying, yeah, we're all sick now, we want this prescription, makes total sense.
Well, so part of me going to the Minute Clinic to get diagnosed wasn't just about the test, to get a positive test, but I needed him to listen to my lungs, because I thought I had fluid in my lungs, which means I could get pneumonia. You can't do that over the phone.
No.
Yeah.
So there's different advantages to showing up.
Yeah.
All right, time is up.
Oh, Hannah has a question.
Let me do one quick one.
Go ahead, sure.
Yeah, first of all, wonderful job. And you handled like the technical difficulties so well. Such a pro. I just wanted to say, well, first of all, I wanted to bring up that I really like the fact that you brought up the drawbacks, especially in regards to access to widespread broadband internet around in certain parts of the world, because that definitely has an impact as to whether or not people have the access to kind of get into telemedicine in that way. But I was just curious as to like if there's any active efforts from international organizations such as the WHO, as well as like NGOs such as Doctors Without Borders, to like mitigate this issue and make it so that people have broadband internet access to participate in telemedicine or not.
So I haven't noticed anything in like the region that I'm studying, which is Swat. But I haven't seen like any intervention from them. What I have seen from like UNICEF is they did go around like would go around to houses and just like do proper like just simple checkups for people, but that was also like once a month type of thing. So up until now I haven't seen it, but it's definitely like worth looking into to see if like they have any type of like the implementation there in northern Pakistan.
Awesome. Thank you.
No problem.
All right, well, thank you guys for your amazing presentations. We hope that next year you guys will be able to participate in person and share your knowledge and excellent research with everyone face to face. It's been a busy day here in Philadelphia. The students are running around, studying and practicing their slides at the last minute. But we had a great presidential luncheon today, a nice dinner last night, and now students are going to be going out for probably dinner with their directors. And we've got 3 online sessions in the morning tomorrow, and then we have an awards ceremony. So we still have some activities. Tonight, you guys are unfortunately going to miss the student gala. It's a big dance. They've got a DJ and hot and cold hors d'oeuvres with the photo booth. But hopefully next year, I'm glad you guys were able to come and participate in any way that you could. So thank you again for what you guys did today.
All right, thank you. Thank you all students. Great session.
Thank you.
Bye-bye.
Well done, everyone.